Hello everyone, and welcome. My name is Arjun Ranga, representing SportsMedQs. Today is an introduction to Ballet for sports and exercise medicine. Before we get into the data and specific pathologies, I want to establish the core philosophy of this talk. Over the years I've spent treating dancers, the theme I continually return to, and will emphasize throughout this presentation, is strength and technique. These two words are our foundation. They are the key words for everything we do. Whether you are dealing with a pre-professional student or a principal dancer, having a deep understanding of their strength and technique is absolutely crucial to achieving successful treatment outcomes. Key literature informs our approach. This includes Kahn's 1995 research on osteoporosis in retired dancers, studies on hip pathology, and resources addressing anterior tibial stress. To treat dancers, you must understand their environment. Classical ballet has been around forever. The ultimate goal on stage is to make incredibly demanding physical effort look completely effortless, graceful, and beautifully in time with the music. It is a rigid, rule-based art form. Traditions of teaching are passed down, and dancers tend to stick to these biomechanical guidelines to succeed. However, this means they live on the absolute boundary of human physical performance. They are driven by audience expectations, because people paid to see exceptional, not mediocre. Add to this the aesthetic pressures from artistic directors regarding muscularity and thinness, and you create a perfect storm of energy supply issues and injury risks. When managing dancers, context is everything. Generally, we are working with elite athletes who are physically built for this profession. Our job is load management and keeping them on stage. Then, you have to consider the environment. Unlike a standard sports pitch, dancers are dealing with changing theaters on tour, varying stages, varying floor densities, and even costumes that restrict vision. At the other end of the spectrum, we have the amateurs. In everyday clinical practice, you'll see passionate students heavily encouraged by their studios, who physically may not be suited for elite classical progression. Sometimes our most difficult, yet constructive job is subtly redirecting these young athletes away from movements that are causing repetitive harm. Let's look at the numbers. At the elite level, these dancers are performing around 100 shows a year. But it's not just the sheer volume, it's the diversity of the workload. I like to call it the heptathlon of dance. In seasonal sports, athletes often do the same movements year-round. A dancer, however, might perform one highly demanding ballet at night, wake up and do a standardized morning class, spend the afternoon rehearsing for a completely different upcoming show, and then learn choreography for a third. This massive variance in required physical capability and endurance creates unique challenges. The number one risk factor across almost all sports applies directly to ballet: previous injury. Whether due to inadequate recovery or compensatory biomechanics, past injuries drive future problems. But ballet has a unique temporal risk factor: production week. There is inevitably an injury spike the week before opening night. Dancers and choreographers are desperate to get it right, pushing to run it one more time. So what are we actually seeing in the clinic? For 30 years consistently, posterior ankle impingement, often related to the os trigonum or the ballet bone, remains the most common clinical presentation. However, when we look at actual time loss, foot and ankle fractures lead the pack. We also manage a significant amount of acute ankle sprains, sometimes from sheer trauma. For instance, tomorrow night we open Romeo and Juliet in Brisbane. They use real heavy swords for the fight scenes, because foam doesn't sound right to the audience. Mishaps happen. Finally, as dancers reach the later stages of their careers, degenerative changes become a primary focus for management. I want to touch on the psychological component, which is inseparable from the physical in this population. Perfectionism is deeply embedded in classical ballet culture. Dancers are actively encouraged to repeat movements endlessly until they are flawless. As clinicians, we have to manage this mindset. Doing a technical element 3 times correctly is highly productive. Doing it 10 times when you are already fatigued is dangerous. We have to help dancers and teachers realize that over-rehearsing brings diminishing returns and drastically spikes injury risk. To wrap up, successfully managing ballet injuries means understanding the art form, the grueling schedule, and the psychology of the dancer. We need to work as a cohesive team, clinician, dancer, teacher, and director, to ensure longevity and health in this incredibly demanding profession.